100 years ago, a deadly influenza virus infected hundreds of millions of people.
Somewhere in the order of 50 to 100 million deaths.
When we talk about another flu pandemic happening, it's not a matter of if, but when.
A new strain of bird flu.
This is definitely one of the most lethal influenza viruses that we have seen so far.
It just takes one person to start an outbreak.
It will leave its mark. The result would be hundreds of millions of people that would likely die. That's why I do what I do.
We're making a vaccine that could treat all future versions of flu.
This vaccine could eradicate influenza as we know it.
We are in charge of our children, not the government.
The problem's so widespread, the World Health Organization is calling the refusal to vaccinate one of the biggest threats of 2019.
A healthy child has the ability to build up immunity naturally.
I know that what I do is important to my patients, but what am I doing to myself and my family?
Within 1 month, the virus can spread throughout the country. A month after that, widespread throughout the world. The next pandemic is going to start, and we just don't know where or how, but we know it will.
That poses an existential threat to us as a species.
Hello, everybody. My name is Aruj Imtiaz, and this webinar is brought to you by Open Silicon Valley. Before we start, a few quick housekeeping rules. Please mute your lines, type in your questions in the Q&A window, and we will get to the questions towards the end of the webinar. Let me begin by first welcoming our honorable guests, Dr. Saira and Dr. Uzma, and thanking them for their heroic efforts during these times. In this time of uncertainty, we are blessed to have people like them to help us guide us through this pandemic so we can navigate our lives through this new normal. A brief introduction. Dr. Saira Madad is an American pathogen preparedness expert. She's the Senior Director of the System-Wide Special Pathogens Program at NYC Health and Hospitals, where she's part of the New York City's response to the coronavirus disease pandemic across the city's healthcare system. She was featured in the Netflix documentary series Pandemic: How to Prevent an Outbreak. Dr. Uzma Saeed is an infectious disease specialist, education leader, civic and political activist, and a humanitarian. She's the founder and president of a nonprofit organization, Align Us, that provides career mentorship opportunities to high school students to better equip them for entering college and the workforce. She's chair of the COVID-19 Task Force, WHO Training Healthcare Preparedness for Epidemic Expert, member of Antimicrobial Stewardship Committee, and Infection Prevention Committee at Good Samaritan Hospital Medical Center. Uzma is also a member of the Inclusion, Diversity, Access, and Equity Task Force of the Infectious Disease Society of America. On behalf of OpenSV, welcome Dr. Saira and Dr. Uzma. This webinar will include a presentation by Dr. Saira regarding the guidance around the pandemic, and by Dr. Uzma regarding the clinical aspect of treatment. On to you, Dr. Saira.
Great, thank you. Can you hear me?
Yes, we can.
Okay, excellent. So first, thanks so much for having me and for the opportunity. Will you be showing the slide set?
Yes, the slides should be coming up shortly.
Excellent. So while Aruj is going to put the slide set on, let me just go ahead and get started. So there's really three main things I'm just going to briefly cover. So where are we? Where do we need to be? And then just providing some guidance as it relates to this pandemic, both at the individual level of what we can do, as well as, obviously at the community level, if you will. Next slide, please. So where are we? All right, so this is something I'm sure everybody's acutely aware of just because it's all around us, it's all over the media, but just to give you a bit of a refresher in terms of where we are and where we stand as of today. There is widespread community transmission of COVID-19 in over 6 continents around the world. and over 212 countries and territories are reporting cases, clusters, or outbreaks of coronavirus disease 19. So around the world as of today, over 3.8 million cases and over 260,000 deaths. If we come down to the national level, so here in the United States, what we're seeing is about a little over 1 million cases and 75,000 deaths. When we talk about the number of cases and the fatality that's increasing on a daily basis, just over the past day, or basically over the past day, so a little less than 24 hours, we've had a jump in 25,000 cases around the United States and over 2,500 deaths being reported. Now, if we bring that even more to kind of the local level here in New York State, we have over 320,000 confirmed cases. And just as of today, based on the past 24 hours, over 2,000, an increase of over 2,000 cases just over the past 24 hours. In terms of the number of deaths, we've had over 230 deaths just today. What we know is that all these numbers that I've just shared is a gross underestimate of what we're actually dealing with, not just here in the United States, but also around the world. And one of the main reasons for it is because of obviously our diagnostic capabilities. And I'm going to talk a little bit more about that in the next slide, but just to stay on where we are. I wanted to give a little bit more perspective, just in terms of, how widespread, obviously, this pandemic is. Everybody knows, in terms of a pandemic means it's all over the world, if you will. But, if you look at where we started and where we're currently at, on March 1st, the United States had a little over 100 cases that we knew about. And 2 months later, we have over 1 million cases. So within that 2-month time frame, what we can gather and what we know about this particular virus is just how highly transmissible it is, and how this translates to in terms of how fast it can spread in the human population. And so when we talk about in terms of spread from an individual person, we talk about it essentially in the sense of, the reproductive rate, if you will. So right now, there's some debate of what that or not could be, right? I think there's consensus over about 2.5 individuals that one infected person can potentially infect. So you hear anywhere from 2.5 to sometimes a little over 3 to 4. So if we stick with that 2.5 number, we know that if each COVID case leads to 2.5 more cases, then over 5 days, a single case will then lead to 244 new cases over a period of a month, right? So that's obviously a very big drastic jump between one case and then translating that into 244 cases, if you will. And that's obviously just on the low ball, if you will. And I'm going to talk to you a little bit more again about where we need to be and how that translates into what we've already done. But certainly, the big question is, are we near the end? And looking at the numbers that we have, looking at the rate of increase, the hard truth is absolutely not. In fact, we are just at the beginning at this pandemic. If you look at obviously when it actually started, we're only just a few months in, and unfortunately, we are certainly still at the beginning, and we still have a very long way to go. And in order for us to go back to any form of normalcy, if you will, there needs to be a lot more that has to be done, both at the political level as well as at the public health and healthcare delivery level that I will talk to you about in a moment. Next slide, please. So where do we need to be? So this is kind of the key question everybody constantly asks. What is the trajectory? Where do we need to be? And what can we do to get there? So in terms of where do we need to be, there are a couple of cornerstones that we need to do in order for us to see any type of improvement with coronavirus disease 19 without an effective vaccine or therapeutic. And Dr. Usmasai is going to talk a little bit more about that, so I'm not going to spend any time on it. But in between kind of the pre-vaccine phase and once we actually get to a vaccine, there's a few things that we absolutely have to do. First, it requires diagnostic testing capacity. So right now, just over last week in the United States, we were able to conduct 1.6 million tests for diagnosing coronavirus disease. That is unfortunately nowhere near where we need to be. We need actually at least 2 to 3 times that on a weekly basis, so anywhere between 3.5 million per week. And the reason for that is that we need to test anybody that actually requires to get testing. And the reason for that is that we need to make sure that we're able to identify these cases right away. We're able to isolate them, do contact tracing, and then quarantining the individuals. And that requires a lot of resources and manpower. And when we talk about contact tracing, it's much easier said than done. You know, we've been doing contact tracing for many, many years for a number of different infectious diseases. And because of the sheer magnitude of this current pandemic, there needs to be a much larger workforce. The other thing we absolutely need in terms of, you know, where we need to be is more data. We need to see where these cases are actually coming from. And what that means is that, are they happening more in the home setting, in the nursing home setting, you know, in congregate settings, things like that. And while it may be intuitive, we absolutely need to see where this data, where these cases are lying, so that way we're able to do more specific interventions. So you may have heard Governor Cuomo earlier today talking about the large number of cases that we're seeing here in the state of New York are actually being diagnosed based on those that are getting infected at home. So one of the strategies that we have in New York City, and one of the things that I'm actually part of, is implementing and standing up these hotels. So we can offer a hotel for an individual that is infected, and if they're not able to socially distance themselves, you know, at home and isolate themselves, because what we know is social distancing is a privilege. Not everybody is able to actually isolate themselves from their loved one, and one of the reasons is because they live perhaps in an area where, you know, they have a lot, you know, a large family, a big family, and, you know, smaller space, if you will. So we are able to offer them a hotel room, and they're able to, you know, stay there until they're no longer infectious and then go back to their home. And so a big part of the contact tracing is obviously being able to identify these individuals and then quarantine them and their contacts. And that's something that we are actively working on from a state perspective. The other thing we absolutely, you know, need to do is increase healthcare capacity. So if you look at the data that we have, over 20 different states are going to be reaching their peak hospital resource capacity. And what this will translate into is, unfortunately, a lot more morbidity and a lot more deaths, because we need to make sure from a healthcare capacity standpoint, we absolutely need our frontline staff to be able to have the resources that they need to respond to the pandemic. So this not only includes personal protective equipment, but a lot of the equipment and supplies and the bed availability and the workforce that goes behind it. So that obviously is one thing, and we need to continue to bulk up and make sure that we have, as some of these states continue to open up and lift some of their social distancing measures that's being implemented. So a few other things in terms of where, you know, we need to be. So not only do we need better data to be able to see where these cases are coming about and do more specific interventions, we need to obviously increase our testing capability across the nation to be able to test anybody that absolutely needs it. We need to be able to do contact tracing and then offer these individuals that are infected a place if they can't socially distance themselves, they can't isolate themselves, so that way we're not starting these new chains of transmission, because the entire goal is making sure that we are not starting these new chains of transmission. We want to make sure we are identifying new cases that can lead to clusters that can lead to outbreaks, and outbreaks that can lead to epidemics. And so it's extremely important that we're able to follow through on all of these if we want to go to any form of normalcy, if you will, in the coming weeks to months to even years. And so in terms of trajectory, we're obviously going to be in this, you know, for the long haul, unfortunately. But there are things that we can do right now to be able to, you know, make the situation better. The only thing that social distancing has been able to do for us, which has been really the biggest weapon in regards to this pandemic, is really not only buy us time to be able to create this infrastructure and system that we need in place, but also it's enabled us to suppress the virus itself. So a lot of people think, you know, flattening the curve means that, you know, the projected number of cases and deaths we already knew about, and that we were just able to elongate that over a period of time. That's actually false. When we say flattening the curve, we were actually able to even suppress the number of cases and deaths that would have been attributed had we not implemented some of these social distancing measures. So not only was it able to buy us time, but obviously it also enabled us to save more lives, if you will. And that's obviously, you know, a huge factor. And so when people ask, well, you know, we've already flattened the curve, that was our main goal. No, the main goal was buying us time to be able to implement and have these infrastructures in place that unfortunately we are still working on. So as you see some of these states lifting these measures, they are nowhere near meeting any of these criteria that we need in order for us to be able to suppress the virus. So what you're going to actually see as some of these states are easing their restrictions, one of the unfortunate parts of this virus itself, and as we know, there's a lot we still don't know about the overall pathogenesis of the virus. This is something we're learning, every day, every week something new comes out. But in terms of the virus, we're not going to actually see the number of cases jump right away. There's going to be this blind or lag time, if you will. So as these states open up, ease some of their social distancing restrictions, it's going to be a couple of weeks until we see really a surge in cases, and that's really due to the incubation period of the virus, and then those that obviously will seek healthcare services. And so between now and when these, between the next surge, people are going to again become complacent, which is going to really be detrimental, because one of the key facts that we know is the virus is obviously still out there. Nothing has been done in order, in terms of making the virus go away, if you will. And so it's still out there, and so there's obviously more opportunities to encounter the virus and become infected, and obviously add to the case count, if you will. So the biggest enemy obviously for us right now is complacency, and so we absolutely can't continue to have, these, over 20,000 deaths, 20,000 cases here in the United States and thousands of deaths. That can't be obviously our new normal. And we need to make sure that, in order for us to get to the other side, we have a manageable number of cases, and that way we're able to do case-based intervention that we call in public health. And this obviously goes to the fact that we are able to do contact tracing. The reason why we can't do contact tracing right now is because there are just too high of a number of cases for the workforce to be able to do this. So once we have the cases to a more manageable, capacity, we're then able to, deploy this method of contact tracing to be able to get the virus and keep the virus in check, if you will. Next slide, please. So just overall high-level guidance, for this pandemic. So there's really two buckets in terms of guidance. The first guidance is public health. So making sure that you're aware of what your local public health department is telling you. So one of the things in this pandemic is that, not every state is being impacted the same way or at the same time. And that's just obviously due to a number of different reasons. Even within the state, you're seeing a number of regions being impacted different, during different intervals and at different rates. Here in New York City, I'm sure everybody has heard of one of our hospitals that's part of our healthcare system, New York City Health and Hospitals, Elmhurst, which was one of the first hospitals to get overwhelmed. It was absolutely by no surprise or by accident that was the first hospital to get overwhelmed in New York City, just because of a number of different factors. I think the biggest is that it's located in an area in New York City, which actually has the most diverse zip code, in the United States. And you have a lot of individuals that live in that particular area that come from various backgrounds, and you see a lot of health disparities within that particular community. But on top of that, you see that a lot of individuals tend to live in smaller homes. So you may have a 2-bed apartment with, 2 families in there. So this is where we say social distancing is a privilege, because they were not able to socially distance themselves. And if one person was infected, then everybody was able to get infected, if you will. And so the 2 buckets that we have in terms of guidance for this pandemic is first making sure that we're following public health guidance based on, what you're facing in your particular region, in your particular locality. So this includes obviously if you still are, sheltering in place, depending on the way state you're living in, that's very important that you abide by your public health guidance. The second is obviously making sure that we're keeping that 6 feet distance between each other. We're continuously following, respiratory etiquette, wearing face masks if we are going out and anticipating contact with others. If we are sick, obviously self-isolating ourselves, and then, avoiding congregate gatherings. So these are just some high-level public health guidance depending on, what state you're currently living in. And the biggest is obviously continuing to stay informed, because as things continue to change, the guidance will also continue to change. So for example, if you're not sheltering in place right now because the state has eased up restrictions, that may go back in effect if the cases continue to exponentially rise. So when we talk about this public health guidance, the whole point is really reducing the chance of getting the infection itself, right? So we want to reduce the number of people getting infected. The second bucket is, besides the public health guidance, the public health guidance does nothing for you in terms of increasing your own personal resilience, right? So following public health guidance, it decreases your chance of getting infected, having an encounter with the virus. we need to obviously make sure that you also have your own prevention kit, if you will. And what this means is increasing your own personal resilience. And so it's never been a better time for you to quit smoking. It's never been a better time for you to make sure that your blood pressure is under control or your diabetes. And what this enables, for an individual level, is that if you do come in contact with the virus, then you're suffering less and you have a faster recovery rate. So you have less of a severe case, if you will. So the healthier you are, it'll translate into, if you do get infected, then you have less suffering and a faster recovery rate. Obviously, there are always outliers, and what we're seeing here in New York City is that no one is invincible. While we're focusing on, the high-risk populations, which do make up a large portion of the cases, another large portion of the cases are those that are between the ages of, less than 60 years old in New York City. And so no one is invincible, but a number of individuals obviously are coming in with underlying medical conditions. And so we want to make sure people understand that we want to make sure that, you are also, maintaining your own health. And this will help increase your own personal resilience if you do get infected. So the public health guidance reduces your chances of getting infected, and God forbid if you do get infected, we want to make sure obviously that at your own personal level, you are maintaining your own health. That way you have a higher chance of suffering less and recovering faster. So I'll stop there and pass the baton over to Dr. Isma Sayed.
Thank you, Sarah. Dr. Isma, on to you.
Yep, I'm just going to see how I can share my screen here. Okay, can you see this?
We can't see anything yet.
Zoom out.
There's a screen share. Oh, there we go. Something is coming up. There we go. Yep, we can see it now.
There? Oh,
yes.
Perfect. All right, it's working. All right, I'll try to keep this as less technical as possible. Some of these slides may be a little bit too medical, but just a brief overview. I'm sure most people are pretty familiar and comfortable with given that we're in the pandemic right now, and I've heard a lot about coronavirus, but as Sarah mentioned, we are still learning quite a bit about this novel strain, SARS-CoV-2, that we are currently in the midst of this COVID-19 pandemic. So basically, coronaviruses are respiratory viruses that have been around for some time now, and essentially they're a group of viruses that come around mostly in seasonal peaks, and they belong to family Coronaviridae, and they do often have frequent mutations, and their clinical course can really be variable. Most of the time it's mild respiratory illnesses. However, when you have different strains coming about in certain years, such as SARS and MERS that we've seen more recently, prior to this, we've seen more severity of illness with that. So people have had severe acute respiratory distress syndrome, they've had mortality, a lot of variability in clinical presentation. And the same goes for COVID-19, which is caused by SARS-CoV-2, which is the name of the virus. So most people have probably seen this image quite frequently in all kinds of media, and it's a very, very characteristic picture of the coronavirus under the microscope, and as you see, it has a very characteristic appearance here, and that's really how it was named. It has this crown-like appearance there, and that's where the name corona came from. It has 4 different genera: the alpha, beta, gamma, and delta, and MERS and SARS and essentially SARS-CoV-2 are all from the beta genera. So because of its close relation to SARS, it was then named SARS-CoV-2, and it is an RNA virus. So what that means is it contains, over 29,000 nucleotides encoding for over 9,000 amino acids, and very, very characteristic, this spike protein on the surface, on the envelope of this virus. And that's going to be important as we talk a little bit about vaccines down the road. Clinical syndrome, it really varies, and that's something that we found very, very interesting with this novel coronavirus. Most common symptoms are, fever, cough, and shortness of breath, but we've seen a very wide presentation where we have people that are essentially completely asymptomatic and, still transmitting the disease. We've had people that have been termed pre-symptomatic where they're still incubating the virus and transmitting it without really having symptoms. And then we've had people on the wide spectrum where they have very mild symptoms and all the way down to the very severe illness that are requiring hospitalization, intensive care stays, and even needing to be on a ventilator. People have had some atypical presentations with gastrointestinal symptoms, some diarrhea, some vomiting. People have had skin findings, loss of sense of smell, loss of sense of taste, some neurologic manifestations as well. So really wide spectrum of illness we're seeing. The fevers, the curves can be really variable. You can have prolonged fevers, you can have intermittent fevers. There's the spectrum of this illness where people start feeling sick, get a little bit better, and then around the second phase of this, they start feeling much, much worse. The respiratory symptoms can really progress where people are going to something called acute respiratory distress syndrome, and that's when they're really requiring high levels of oxygen and may even need to be on a ventilator to assist with their breathing. Gastrointestinal, people very commonly are having diarrheal illness with this syndrome as well. It can affect multiple organs, as the symptoms progress and as people are having more severity of symptoms and of illness, we start seeing multiple organs being affected. Kidneys very, very commonly do get affected by this and essentially can shut down, where people then will require hemodialysis and support to really help their kidney function along. People oftentimes need different types of medications to assist to maintain their blood pressure. A lot of times people have neurologic findings, as I mentioned before. They can come in with a lot of confusion, some type of encephalitis. They can have skin manifestations. We're seeing a lot of coagulopathy with this, where people are coming in with extensive blood clots. And this can even lead to strokes. So, atypical presentations where people don't even have respiratory symptoms, but they're coming in with stroke-like presentation. They're coming in with what's called a pulmonary embolism, a clot in their lungs, and they have blood clots all over. And this is really a manifestation, a secondary manifestation of this disease, and unfortunately, eventually leading to mortality and death. Some of the radiographic findings, you can see over here on the left side is basically a chest x-ray that's essentially clear. And the same patient then had a CAT scan, which showed, over here, these classic infiltrates, the lung findings that you see at the very peripheries. And then, when I spoke about the ARDS before, this is what, what I showed you previously was a normal lung, and this is what a lung that's infected with COVID looks like. And some more CAT scan findings of these patients. Now, after, the clinical spectrum, we really move on to diagnostics. And, this is really where we had some challenges early on, as we were dealing with this novel virus. And, we were following this very closely from December out of China, and then eventually anticipating, its arrival into the US, although we weren't aware that it had already, there were already cases here that were not necessarily being picked up, because essentially our diagnostic criteria was so stringent in the beginning. And once, the test kits were dispersed by the CDC, there was a very, very strict protocol for diagnosing these people, and they had to meet the criteria of, whether they were travelers, whether they were visiting specifically from China. And now we weren't even looking at travelers from anywhere outside of that. And so, the first test essentially that was developed was a molecular test, which was a PCR test, where we would do a nasopharyngeal swab, so a swab that goes in from the nose into the back of the pharynx to really get the best specimen with the most amount of viral load, so that we can have a good adequate sample, so that we can in fact know that it's a true positive or a true negative. So this detects virus. So as I mentioned before, we were a little bit limited with our diagnostic testing in the beginning, and there were multiple things that happened that created some breakdown along the way, whether it was limitations in testing or actual problems with the testing kits. and problems with the reagents and assays, and it really sort of put us behind, on our timeline because, we had bought ourselves a little bit of time initially with, seeing what's happening in China and then Italy and then having certain travel restrictions. But unfortunately, once we got limited with our testing abilities, we sort of had lost that time. So now that's the standard of diagnostic for diagnostic testing. That's the gold standard, is the PCR testing. We have moved forward now. We're moving along now to serologic testing, which is essentially antibody testing. But this, something that people need to be aware of is that this is not usually what's used for diagnosing somebody with acute COVID-19. So the antibody testing are really important for epidemiologic perspectives. It's really important to see where, there may be clusters of illness, who might have been exposed, especially when we're looking at those asymptomatic carriers, to see what's happening geographically. Antibody testing is often important for us to look at, for vaccine responses. So, as we talk about vaccines in a moment, after somebody's challenged with a vaccine, we want to see, does your body mount the appropriate response to this? Do you have immunity or not? And equally so, antibody testing is very good for surveillance. But for those particular reasons, it's not something that we use necessarily for diagnosing somebody immediately that has it, because, this is not something, for us, we want to look at specifically their viral load, and the PCR testing is very, very good for that. Now, there are some challenges, with, the various antibody tests that we have available. For the most part, there were so many tests that were rolled out that a lot of these tests needed to be validated. So although there's lots of tests that are out there, not every test was FDA approved, not every test was validated, and there was, means for lots of conflicting data from all these tests. For the test to really be good, you really need to have a very high sensitivity and very high specificity, meaning that you are getting a true positive result and you are getting a true negative result. Because some of these tests, what you really want ideally is a test that picks up neutralizing antibodies to SARS-CoV-2, so that you are in fact diagnosing that. Some of these tests, they have overlap with some other strains of coronavirus that we see seasonally in other years, and so sometimes you might have a positive test result, but that in fact is a false positive. So then you're left with this unfortunate, sense of, security that is false. And then, you might be at risk of acquiring this again. So a lot of little hindrances on there, but, things are, working, it's a work in progress, and hopefully there's more and more improvement on this. And recently, there's some tests that just came out this week from Roche, and, we're going to have to wait and see. They are saying very high specificity and sensitivities for their tests. So, we are working towards that goal, but unfortunately, when you're in the midst of a pandemic, a day is like a week, and a week is like a month, and a month is like a year, and you just can't seem to be moving fast enough. You need to keep moving faster, and all of these things, as quickly as things are moving along, is just not fast enough, unfortunately. So just looking at some numbers, as Sarah had mentioned before, we have over 3 million cases worldwide. If you look at the United States alone, over 1,200,000 cases. Globally, we have over 260,000 deaths from this, and over 71,000 deaths just in the US. Looking at the map of the United States, pretty widespread disease, but obviously you know that there's epicenters and hotspots in different areas, New York being the prime epicenter of COVID-19, and now you can see there's other areas throughout the country that have been affected by this. Just looking at number of deaths, as I said, globally over 262,000, but if you look at the number of people that are recovered, it's over 1,279,000. The difference in that are the people that are actively ill with the disease right now. So when you look at the active cases, you have over 2,253,000 active cases, and of those, over 2,205,000 of those are in mild condition, whereas 48,000 of those are in serious condition. And then the closed cases on the right is over 1 million, and you can see that from there, that's where we have the 262,000 deaths that have happened, and over 1,270,000 people that have recovered from this. Now, if you look at the graphs at the bottom, looking at the total number of cases and the total deaths, you can see that we really, from January till now, still have a rather steep incline of the number of cases and the number of deaths. So, we are, as Sarah mentioned, we are in the midst of a pandemic, and this is not something that is, unfortunately, we are not past this by any means. And so we are actively in this pandemic. And, what's really important for us is to really know the case fatality ratio. And what that is really looking at the number of people that have had mortality in the divided by the total number of cases overall. And when you're in the middle of a pandemic, you really can't come up with that case fatality ratio because you don't know that denominator number. You don't know the final numbers of, mortality or the total number of people that were affected. But what really helps with that is knowing really having as much adequate testing as possible to know really what is fair representation of the number of people that have been affected by this. Because as we know, we are really still represented with the numbers that we have to date. And that's really just going to improve with the more testing that we have to offer. So differences in mortality of these numbers can be caused by, differences in the number of people that are tested. As I mentioned, the more people that we test, the more people that we know that are positive for this, the lower our case fatality ratio is going to be. So as of now, globally, we're saying 17%, but it may in fact be lower than that once we're able to really test everybody. Demographics, that causes a difference in mortality as well. And we can see that specifically in New York and, in the United States, we've seen that there are people that have been, completely, more susceptible and more races have been represented as, having higher mortality specifically in the African Americans and Hispanics. So, that accounts for a difference in that as well. And then again, how the healthcare systems handle this leads to that number as well. So if the hospitals do in fact get overwhelmed, and then they'll have fewer resources, and that's going to affect your mortality rate as well. So all of these factors really go into this. Cases and mortality by country, again, mentioned before, United States over 1 million cases, over 71,000 deaths, and our percentage rates are right there. But again, as I mentioned before, that while we're in the midst of this pandemic, this number is expected to change. And if we're just looking internationally, we have, all these cases listed in India, in Pakistan, and all over the world, really. Looking at the United States, again, these are the reported cases, and it's pretty widespread, disease that we have in the U.S. as well, with certain areas being hit harder than others, obviously. As I mentioned before, New York was the epicenter, so you can see it's pretty darkened out over there. But then soon after that, we had some neighboring areas that became pretty heavily affected by this as well, including New Jersey and Massachusetts. And then soon after that, we saw that there was a lot of cases happening in Illinois, Michigan, Texas, Florida. You can see the areas that are darker that are really having more cases. And if you look at the graphs and the data for the cases of COVID-19 from January 22nd till now, you can see that in the United States that our progression has been, we've had this steep incline, and then we've sort of had, a little bit of peaks and valleys along the way, but really no sharp decline the way that we had this sharp incline here. If you look at Italy, they also had a very steep incline, but then their, slope down has been a little bit steeper than ours. And then United Kingdom is sort of, hovering around, the same area. And so their incline actually was much slower than ours. But it's really interesting to see how the different countries are, dealing with this pandemic. So this basically shows the cases of COVID-19 throughout the US since the beginning of the outbreak. And you can see that we've had several peaks, and really in April is when we were, looks like our highest numbers. And then since then, depends on geographically which region you're in. Certain areas have had a little bit of plateauing while other areas continue to grow. In New York specifically, just looking at some of the boroughs, you can see the number of cases that are affected by this. Bronx, followed by Staten Island, Queens, Brooklyn, and Manhattan. And when you break it down by age groups, we always said that, the elderly population was going to be most hard hit by this. Anybody from, as the age increased from 70 and up, that they would have higher mortality, especially if they had pre-existing medical conditions that would put them at higher risk of being in the ICU, being on a ventilator, and even having mortality. So we definitely see that here with the 75 years and older. However, we do see significant disease burden in younger populations as well. Even in the 45 to 64-year-olds, they're being really affected by this. And when you look at the bucket of the 18 to 44-year-olds, there is significant disease burden there. And although we had always focused on the adults, we knew that, you know, even though children for the most part were being spared by this, we knew that that was not an indefinite, you know, there would always be outliers. There would always be a pediatric population that would be affected by this. And we've certainly seen that. And if you look at, you know, male versus female predominance here, we knew early on that it was affecting males more, and we sort of still see those trends. And if you just look at New York specifically, you know, we've had very strict, you know, social distancing and sheltering in place orders in effect for many weeks now. And we can see collectively as a state how the numbers have, you know, showed a rather decline in those weeks. And as Sarah mentioned, you know, there really is a lag because the incubation period is so long for COVID-19 that we don't expect to see changes immediately from the actions that we're taking today. You know, so for all the sheltering in place that was taking place, it really was a minimum of 2 weeks before we saw the effects of that. So we are seeing now the effects of all the weeks prior. And so we continue to be on this decline. So as far as treatment goes, as you're aware, there is really no curative therapy for COVID-19 at this point. There are lots of treatments out there that are anecdotal. There are lots of treatments out there that are in clinical trials currently to see if they have any effect, to see if they have any value in treating you know, SARS-CoV-2. Most recently, there was some data that came out of the National Institute of Allergy and Infectious Diseases on a large clinical trial that was being done between the US and internationally as well. Over 1,000 patients that were being treated with a antiviral medication called remdesivir, which is a nucleoside analog. And it's not a new drug. It's a drug, in fact, that was used previously for Ebola. But it's a drug that's been studied, and you know, it has some good data in vitro for SARS and MERS, which is why there was some promise for it. So the very first patient that was actually diagnosed with COVID in the US was actually enrolled in this trial. And so this trial was ongoing, and they found, you know, the Data Safety and Monitoring Board actually found that there was some benefit of this drug. And so they decided to release some of that information just a few days ago. And what they found was that there was a reduction in the duration of illness from 15 down to 11 days. That was statistically significant. And they also found that there was a slight reduction in mortality from 11% to 8%. That unfortunately was not statistically significant. Now, those numbers are very, very small. What that indicates is that this is certainly and by no means a curative medication, but it is the only medication that has so far shown to have some benefit in treating this virus. But what that means is essentially that this is a starting point. It's something to build off of, that new drugs can be developed based on this. And it's a direction that we have to focus on, because up until now, there's actually really no medication that we know that has been effective. So when you're in a pandemic with a novel virus, you know, that's really what you're left with, is finding, you know, a therapeutic, and, you know, and that takes time, because for all intents and purposes, what they're using right now has been repurposing older drugs. There's no new medication that's been, you know, developed because of the time frame. You know, this is, you know, we're only 2 months, 3 months into this whole thing, and we're learning still about the virus. So we don't have that luxury of having all the answers and knowing, you know, what medicine is going to work. So our next and most effective strategy is prevention. And so for us, the prevention has been, when we realized that containment was really a problem because of the high transmissibility of this virus and all the asymptomatic carriage, then we work towards mitigation efforts with all the sheltering in place and restrictions. And that's really where the approach has been. And simultaneously, there's been a huge emphasis on vaccine development as a preventative measure, because until we have a curative treatment, the only other thing that's going to help is working towards a vaccine. Now, I'm sure people have heard this before, but just, would reiterate that vaccine development as well is something that's not, very quick and easy. That's something that takes a good amount of time as well. Typically, vaccine development can take, from a minimum of 1 year to 18 months, and sometimes even longer than that. This is not something that is essentially sped up or, available within, a few weeks time frame. It's a whole process, and it's, very rigorous process. And there's checks and balances in this for to ensure that the vaccine is actually effective and that it's actually safe to be used. So right now we have over 100 vaccines that are actually in development, and we have roughly about 7 to 8 clinical trials that are going on globally on different vaccines. And there's different ways that vaccines can work towards the pathogen. And, specifically for SARS-CoV-2, we're interested in looking at the spike protein and, the antibodies to that. We can look at RNA vaccines, there's DNA vaccines, there's vaccines directed at the protein. So there's all different things out there that are in development right now to see which is going to be the most effective method. So just briefly, a basic about vaccines. You have different types of vaccines. Vaccines have been around for a long time. You have a live vaccine, which is usually a weakened form of, I guess you can say, the germ that causes the disease. And this gives you an immune response without causing the disease. And we have a lot of live virus vaccines that we use currently. We have measles, mumps, rubella, these are all chickenpox, all live virus vaccines. Then we have, killed vaccines, which are inactivated vaccines. And basically, it's a version of the germ that causes the disease, but it's, been inactivated using different methods. So, this gives you an immune response as well, but doesn't give you the infection. And, we have different types of inactivated vaccines, which we use currently, hepatitis being one of them. Influenza, so this is another method that, you can use to get immunity. Sometimes it's not as prolonged as a live vaccine, the immunity. And so for that reason, certain vaccines that you may have heard of before require booster vaccines to give you that prolonged immunity. So basically, vaccine development is, the timeline for that is a little bit long. And the reason for that is, not just that, it has to be put into development, but once the vaccine is actually developed, the first thing that happens is that it gets tested in animals to see if it works and see if it's safe. And after that, and that process itself can take 3 to 6 months. After that, then phase 1 of the clinical trial begins, where we look at, is this vaccine actually safe in human beings? And so once we notice that the vaccine is having, there's safety and, it goes through all the criteria and it's everything is meeting standards, then it moves into phase 2, which is, the formulation of the doses of vaccines are established to prove the effectiveness. And finally, during phase 3, we look at the safety and the efficacy of the vaccine in large group of people. So all of this process takes time, which is why vaccine development takes, 12 to 18 months. There are obviously right now, because of, the time being of the essence, the urgency of the matter, there are several vaccine trials out there that are being expedited. You might have heard of the Oxford trial, that's really moving along very, very quickly, that vaccine. And sometimes, that is a little bit of a concern because you want to make sure that, it is safe, for the general population. The second thing is, even after all of these boxes have been checked and everything pans out, it's not necessarily going to be the case that the large volume of vaccines that are needed, the millions and millions and billions of vaccines that are going to be needed for the whole global population is going to be available right away, because vaccine production takes time. So usually the way that it works is that, they focus on one vaccine manufacturing and then putting it through trials and see if it's effective or not, then they send it to production. But because we are in this really unusual circumstance of this global pandemic that's got such mortality and so many people being affected, there are all of these different vaccines that are actually being expedited and actually are being sent for manufacturing, and expedited for that pipeline as well. So they're not, instead of waiting until the end, they're actually working on, just mass producing so that they can have whichever one of these vaccines works, they'll actually have it ready to sort of go, or have more than they would normally have ready to give to, the first line people. Then the second line, they'll have to essentially derive a formula of who is most at risk, stratify who would get the vaccine first and so forth. But again, all of that would be essentially after, it's been through all these trials and it's been proven to be effective and it's been proven to be safe. And so where does that leave us? Basically, without a therapeutic that's curative, without a vaccine that's preventative, what we have to focus on essentially is continuing our mitigation strategies. As a lot of states are opening up, we do need to be cognizant and be aware that just because things are opening up doesn't mean that life can go back to the way it used to be. We have to be very cognizant of that. We have to essentially assume that anybody that we come into contact with could be incubating, could have the virus, could be symptomatic. And so we have to continue doing the physical distancing. We have to continue the mask. We have to continue our hand hygiene and our, cough etiquette and all of those things, because that's what's going to save lives. And I think the goal in all of this is going to be diagnosing, isolating, contact tracing until we have an effective vaccine in place and an effective therapeutic that's curative. That's the only way we're going to be able to slowly back into opening things up effectively and safely without having constant surges in the healthcare system. That's it. And this quote, I just, love this from the president of Ghana. We know how to bring the economy back to life. What we do not know is how to bring people back to life. We will therefore protect the people's lives than their livelihoods.
Truly a wonderful quote that is. Thank you so much, Dr. Sarah and Dr. Isma. A few questions, and I'll start with Sarah first. Looking at the data that we have for now, when do we think that we'll have the peak and the cycle of the pandemic will be over? Or are we still it's still too early to answer that question?
Right, so it is obviously still too early to answer that question. We have just gone over really the first wave here in New York State, and as I mentioned earlier, each epidemic, this country first is very large, right? So you can think of these states as almost mini countries. And so here in the New York State area, we've only faced our first wave. In other parts of the United States, some haven't even reached their first wave, right? They were able to suppress it. And so the trajectory for all of us across the United States is going to be different. And what we know from past epidemics, past pandemics, and I think the most, comparison pandemic is the 1918, which saw 3 waves, and the second wave actually brought a much larger number of cases, a much larger number of deaths associated with it. Here in the, in the state of New York and here in the United States, we're hoping not to obviously have first a second wave, and then obviously have a wave that has a very large peak. What we know is that a second wave is inevitable because the virus, as I mentioned, is still out there, and there's not much that we have done in terms of therapeutics, and obviously there's no vaccine available to be able to get the virus under control. So right now our biggest weapon, was social distancing, and if that's going to continue to ease up, then you're going to obviously see more people get infected. That's just really the nature of the business that we're going to be dealing with. And so what we have to do is try to suppress the virus as much as we can. And this is where both, Isma and I have mentioned, we need to make sure that we're able to identify the cases right away, isolate them, contact trace, and quarantine. So we're going to constantly play a game of whack-a-mole across this entire nation until we actually have a vaccine available. But even then, with the vaccine, it's not the panacea, if you will. And what this means is that it's going to take, some bit of time to be able to manufacture and distribute across the nation. And all of this is going to take a lot of time to actually even build herd immunity. One of the things we have discussed is obviously this concept of herd immunity, whether it's through inoculation or whether it's through this naturally getting infected. What we know in the United States is that a very, very, very low percentage of Americans actually have antibodies. What antibodies even mean, how and what that translates to is obviously a different story. But we're in the sometimes in the single digits across the nation, and so natural immunity is obviously going to take a long time to build up. For herd immunity, you need at least for this particular virus, based on the reproductive rate, at least 60 to 80% herd immunity for us to see any significant improvement. And so we know that these second, third, fourth waves are going to be inevitable. They're going to happen. What we need to make sure is that we have that infrastructure and system in place to be able to respond to it properly, effectively, and safely. And so the difference between now and the last peak here that we faced is making sure that we have these systems in check, or else we're going to be back in the same state that we were in March, unfortunately. So that's really just the reality of it right now.
Thank you. So one of the questions that we have is that your advice on developing countries where we don't have any good and mature testing facilities and not a good general public health system and infrastructure, how would they deal with this? I guess.
This question for, yeah.
Maybe it's for you, Sarah.
Yeah, sure. And I'm happy to start off, and then Uzma, if you want to jump in, certainly feel free to do so. So one of the things not surprising that we've learned in this pandemic, this is something that we've known for all pandemics and epidemics we face, is that we live obviously in a very globalized world, and that we need to ensure that not just here in the United States that we have a good healthcare infrastructure, but other countries around the world have a great infrastructure. Because what you're seeing in other countries like Singapore and countries that have been able to at least get their epidemic under control, what they're facing now is the reintroduction of cases through travel, right? So we live in a society where we have very porous borders, right? So people are constantly moving in and out, and so now there's a risk of, people bringing in the disease, even though your particular state was able to get the epidemic under control. And so when we talk about that in kind of the, countries outside the United States, those that obviously have a poor healthcare infrastructure to begin with, those that don't have the public health capabilities, this is where these preventative measures go a long way. So first, there's the government aspect of it and the healthcare aspect and the public health aspect, but then there's also the individual aspect. So the behaviors that we can do that influences us to come in contact with the virus itself, right? We want to continue to advocate for our elected officials, whatever country you're in, to be able to have this infrastructure in place. But if you don't have that, then you want to make sure that you're doing these everyday measures. So, if you're not going to come in contact with the virus, obviously you're not going to get it. And so the best way is to be able to, socially distance yourself, shelter in place, especially if you're in the high risk category, washing your hands, covering your cough. So these are really things that will help kind of mitigate. But again, there's multiple layers to the response. You want to make sure you have a local response, a state response, and a federal or national response. But those are things that obviously still need to be worked out. Uzma, anything you'd like to add to that?
Yeah, sure. No, that was great. So, this has been a huge concern of mine, and I'm sure yours and a lot of people across the world as well, is that, when developed countries are struggling to deal with this, how do these underdeveloped countries that, unfortunately don't have access, they have extreme crowding scenarios, they don't have access to clean water, they have so much poverty, how could they potentially cope or, deal with this situation that, is essentially impossible? The burden of the disease will be just so much for them to handle. And so, it's one of those situations where you really need a collective effort from their governments and from people throughout the world to really raise funds and bring awareness and get these people the basic necessities that they need. Clean water. Unfortunately, most of these people don't have the luxury of having the space, in their households when they have multiple people in that household. But, providing them whatever safe scenario that you possibly can, and that starts with basic things, just clean water and having the hygiene that they need. We've also seen this, as you mentioned, in Singapore, where they were able to, deal with the virus really well, but then we saw later on that they had reintroduction of this from the workers that were living in very crowded, housing. And so that was something that was overlooked. So these are all, public health measures that we definitely need to focus on, as we're learning so much about this and going through this pandemic.
Thank you. So there's a question for you, Uzma. Do you speculate that the lower rates of mortality in some Asian countries versus the US are due to a genetic or biologic advantage, or simply due to better social distancing and compliance with stay-at-home guidance, or just not sufficient evidence is available?
I think it's a combination of things. So for the most part, I think a lot of it has to do with testing and recognition of the disease. We know even in the United States that we had the virus was here, the disease was here far before the first person that we documented as having it. And we're finding earlier cases of it. And so, when you test for it, you will find it. And a lot of people have had mortality from unknown causes that we were not thinking about or looking at. So I think that is one thing that can be said for these other countries where they're just, the more that you're going to test, the more you're going to find it. And I think there is, obviously, different social and, economic standards, but also, there may be a little bit more fear in those certain scenarios and certain places in the world where people are sticking to a little bit more of the social distancing, and they are able to do that, whether they're in, little villages where they're not around, urban areas, and they're in remote area where it's just a, very small number of people that are there. So they have less risk of exposure, less travel related exposure with people coming in and out of there. That might have something to contribute to it as well. So it's probably a combination of things.
Great, thank you. So Azmat, another question for you is the role of plasmapheresis. And I have a question regarding, you mentioned that the presentation is very different across, how patients present, but it's sometimes you can have coagulopathy and all these things. It seems like it's an immune response and a hyperactive immune response. So any thoughts about any immune suppression that would help, or does it make it worse?
Right. So that's an excellent question. So as I mentioned before, because we're learning so much about the virus, every day there's something new. There's so much literature that's coming out. There's so much that we're learning just from being on the front lines and in the field. But, as we know in medicine and science, we have to rely on evidence-based medicine to guide us, and it's difficult because this disease is like no other. Nobody's immune to it, and there's so much mortality and such a wide spectrum of illness that, everybody wants to do whatever they can to fix the problem. And, and in medicine, we're very much used to that. We're used to being healers. We're used to, especially in the United States, 95, 100-year-old patients, healing them, nursing them back to their health and getting them out of the hospital. And then here we have people young and no underlying medical conditions just not making it. So it gets to be very frustrating, and people are grasping at straws. So all these different measures have been attempted, but the best way to really know what's effective and the safest way is to follow the science. So you have to do it in a controlled setting. You have to do it in a clinical trial. Only then will you have statistically significant numbers to know if what you're doing is actually helping. Because the first thing that we always say as physicians, and the most important thing, is to do no harm. So you may be trying something, but it may have a negative effect. So we do know that it's a hyper, immune response. We know that there's a cytokine storm in that second week of illness where patients' immune systems are just, in overdrive. And there's different approaches. There's different medications, immunomodulating drugs that have been used, to try to fight that. But there's no way of knowing right now if those are actually effective. And I think you have to let the science come, to that conclusion. Plasmapheresis, same thing, convalescent plasma, same kind of thing. Right now there's clinical trials going on with that as well. And it was used previously with the Spanish flu, and, there was, good results with that. And, we're participating in these clinical trials as well. But until you have all the data, there's, it's really hard to say what actually works. So as of now, there's nothing that has been proven, with the exception of just those slight numbers, from remdesivir. But these are all things that are being looked at, and, time will tell.
This is a question for both of you. Are there several strains of this virus, or there is just one, or is this virus going to mutate when we have the second wave come in? Do we need to be mindful of the fact that it can come next year to not just 2020, but 2021 mutated, as we all know the viruses can, and how prepared are we for that? Anybody who wants to take the question first.
I'm happy to start off, and if you'd like to add. So in terms of, the virus that we're dealing with right now, so that, as Asma stated, it's an RNA virus, and RNA viruses are prone to actually mutation. So this is not something new. This is not a new phenomena. This is something that we know just based on the family that this virus falls under. Mutations necessarily do not mean it's a good thing or a bad thing. It really depends on the biological significance of it. And so what we know right now with the coronavirus disease, or SARS-CoV-2 virus that we're dealing with, is that it is mutating, but not at a significant there's no biological significance to it yet, and we need to see what the data and the science is showing. When RNA viruses do replicate inside, for example, a human body, it's not uncommon for one of the bases, for example, to be changed. But overall, the virus is almost 99.9% identical to other strains that are out there. Right now, obviously, this is something that is in the news a lot, right? Currently, I know the LA Times obviously came out with something earlier today saying that one of the strains is that's more dominant is associated with higher lethality and is more virulent. Right now, there is no data to back that up. There are a couple of different strains of this current, disease itself, but they are all clinically very similar. And again, as I mentioned, there's no biological significance right now that we can tell.
Yeah, I was just going to say exactly the same, that we know that there's, I had a slide previously, I had taken it out earlier, but it shows the whole phylogenetic tree, and there's, lots of different strains of this that have been identified already, which is how we, have been able to decipher that, the first cases in New York were from, travelers from Europe as opposed to China. And then on the West Coast, it was one traveler from China, one traveler from Europe. So, this is important from, the epidemiologic perspective. But, as Sarah mentioned, usually, these changes and the mutations are not that significant to cause that much difference between. But again, it's still early. We're still learning a lot. So a lot of this is, bound to change. The more that we learn about it, the more that we'll know.
A lot of unknowns still. Do you think the weather is going to play any role in the virus becoming less infectious? And both of you.
Yeah, sure.
Yeah.
So, it's really unlikely. I think, I think we are going to be, dealing with SARS-CoV-2 for some time now. We are anticipating, essentially what's going to be driving, the surges, the reoccurrences, and the volume is going to be, how much exposure there's going to be. But, I don't think that this is something that's necessarily going to be gone. The speculation came out a while ago in the beginning that it was not happening in the warmer climates because of, this and that. But, essentially most of it has to do with a lot of the transmission we were seeing in the most traveled areas first, globally. And then, as I mentioned before, with testing abilities and this and that, you're not picking up a lot of cases. But as things progress and as testing ramps up, you will pick up more and more cases. But I certainly don't think that this is something that's going to be gone anytime soon.
Thank you. Thank you so much, both of you, for going through this wonderful presentation. It's extremely helpful, especially I think everybody on call, I'm sure thoroughly enjoyed it as much I did. Any closing remarks from you, Isma, and then Zaira?
Sure. We just want everyone to really sort of not give up hope. I know it's very difficult and trying times. It's something that most of us have never ever experienced in our lives, and we're all learning. This is a new normal for all of us, and it is scary. It is difficult, to sort of, have everything come to a halt rather quickly. But all of the efforts that everybody has put forward are really working. We've seen, being on the front lines, I've essentially been through what I can describe as a war zone, and it was really, really difficult to go through that. And we still have significant number of people in our ICUs, although the admission rates has slowed down. But all of those things, the lessening of the burden on the healthcare systems, as Sarah mentioned, is saving lives. And that's a collective effort. So although it's very challenging and very difficult, I do want to commend everybody for continuing to do that. And really, it's a matter of, protecting yourselves, your loved ones, your family members, because this is, you don't know who can be affected by this, and it's so communicable. So we have to just continue to be safe and practice, the appropriate measures, even when, things do start opening up a little bit, just be really smart about it and maintain that distance and think about, all of your actions do have consequences. Thank you.
Yeah, this is Zaira. So I think just to add and echo, our behavior has a huge influence on the trajectory of this outbreak. It did on the onset, and it continues to do so. Exactly how this pandemic will end really depends on part on the medical advances that are obviously still yet to come in terms of therapeutics and vaccine. But it also, heavily depends on how, at the individual level, how we behave, and that obviously has a huge influence. And so if we continue to protect ourselves and protect our loved ones in our community, that will obviously, we will be able to reduce the number of people that will get infected and at the end really save lives. If we underestimate the virus, it will find us. It's really as simple as that. And so this is where we want to make sure that people understand our biggest weapon that we have, besides having a therapeutic or vaccine, is our individual behaviors. And if we let down our guard, if we become complacent, then this virus is going to come roaring back. It's obviously already here. It's going to continue to be with us. It's going to be in the backdrop as we continue our new normal, if you will. If we give the virus the opportunity to, find us, if you will, by, not abiding by some of these public health measures of respiratory etiquette, socially distancing ourselves, wearing a face mask, things like that, then obviously we're going to be in the same position that we were just a few weeks ago.
Great, thank you so much. That was very helpful. And as both of you said, we are all in this together. Hopefully we will learn these lessons and, and pass them to our generations to come of what not to do. So again, on behalf of Open, thank you so much, Dr. Usma and Dr. Saira. And I hope you guys have a wonderful evening. Thank you.
Thank you.
Thank you.